The first thing I want to do is just get rid of any shame and any guilt around this condition because you didn't do anything. It was not you minding your own business, having wonderful, intimate, mad lovemaking and wearing braces for your penis. The penis is a pretty amazing organ. I mean, it's resilient.
It looks like there's even cave drawings from like 8,000 years ago, right? Showing men doing penile stretching.
Yes.
Yeah. So
yes.
it's as long as we've been around, probably.
That's right.
Welcome back to the Rena Malik MD podcast. I'm your host, Dr. Rena Malik, urologist and pelvic surgeon. Today's guest is Dr. Jesse Mills. He is a health science clinical professor and director of the men's clinic at UCLA. He is also fellowship director of the UCLA Male Reproductive Medicine and Surgical Program. His practice is solely devoted to urologic men's health issues. He is internationally recognized as a thought leader in male fertility, hypogonadism, erectile dysfunction, Peyronie's disease, and microsurgery. Today, we talk all about Peyronie's disease and infertility. In this episode, we discuss what exactly is Peyronie's disease, what causes it, and can you prevent it? We also talk about the mental toll of having Peyronie's disease and how to manage the condition either conservatively with injections or surgery. We also cover some hot button topics in infertility, including do saunas and red light actually impact your fertility? What supplements are actually going to help your fertility? And why are sperm counts decreasing worldwide? I hope you guys enjoy. All right, Dr. Mills, welcome to the podcast.
Thanks so much. This is really cool to be here. I appreciate you.
It's really exciting to have you. We're so local, almost, basically. So it's exciting. So tell me, you have done a lot of work in Peyronie's disease, which is sort of a curved penis. So the audience wants to know, how bent is too bent?
Well, yeah, I mean, I would love to set the tone by trying to get away from it being called a disease. You know, it's very stigmatizing, and there are guys that just because of the question you asked that are perfectly happy having a bend and maybe even some scar tissue in their penis, and their partners are perfectly happy as well. So what really you have basically is a tissue healing disorder that leads to some change in what the guy's penis used to be. And so whether that's for him or his partner, I have men that come in that have even what I can't tell is a bent penis. And I can tell you the number of men that come in. You remember those books when we were kids that you would flip through and it'd be that stop animation, you keep flipping, and you would see the person doing something in action, playing tennis, something. They have stop animation of their penises. And so from 2016 to 2022, they may have 18,000 photos of the penis that they go through. And I can barely even tell the difference from some of those men, which goes to show that it's as bent and it's as bothersome as they think it is. And I think that's the huge distinction about this condition, is that it really isn't, it's all in the eye of the beholder or the beholdee.
Yeah, and there is a natural curve to a lot of penises. So I reviewed a study that sort of looked at the curvature in men who didn't complain of a problem. And there's a wide variation from like 0 degrees to 45 degrees. That's, around 75% of people have some degree of curvature and they're not bothered by it.
Yeah. I mean, while I'm throwing wrenches and even trying to rename the disease on your podcast, I would also love to just bring up the fact that we really don't know how to measure very well. I mean, I did pretty well in geometry and physics, and I thought I was pretty good at it. And we published a study a few years ago that showed that the interoperator variability of goniometry, or basically putting a protractor in the penis, is terrible. It's terrible, and yet we base insurance claims on it. We base the degree that we think men should be treated based on an angulation. And that's just wrong. It really, it shouldn't be, because right. If I've had men that come in with a 65 degree curve and they just want to make sure that they're okay because they're fine, their partner's happy. But as I said, you could find a man with a curve of 5 degrees that is just devastated, just wrecked. It's not the penis it used to be. And of course, we haven't even talked about with curve and with scar tissue usually comes shortening, and I'm sure we'll talk about that as well. But yeah, so curve to me, outside of filing claims to get coverage for certain procedures, it really doesn't make a difference. It's how bad a person is bothered by the appearance of their penis.
Yeah. I think you said it's a disease of healing, right? So what are the things that cause curvature, and are there things that people can do to prevent it?
Right. This will be the fastest answer ever. I have no idea. I mean, we just don't know. We know what the tissue is, and we know what happens when normal tissue goes rogue and lets down a scar, and it's essentially a collagen deposition disorder. So penis is made up of a few types of collagen that tend to be very elastic and allow us to be growers or showers and lead to that incredible physiology of an erection, which is essentially going from almost no blood pressure to 300 millimeters of mercury blood pressure in seconds, maybe even sooner than that, the younger we are. And so you have to have this encasing that's able to handle that high pressure, that high rapid expansion of blood flow into a finite organ. And it's a very nice matrix of beautifully oriented collagen that goes in two layers. You've got longitudinal layers, you've got circular layers. And then what happens is something, as you were asking me, I still have not been able to answer your question, haven't forgotten it though, is that in between those layers, the longitudinal and the circular fibers, somebody just decides that they don't want to be normal collagen anymore, and they start secreting abnormal collagen, typically type 1 and 3 of all of the 7+ subtypes of collagen. That leads to essentially a piece of just very inelastic collagen and an otherwise very happy elastic membrane. And the prevailing theory, and we have yet to actually come up with a good model to induce Peyronie's disease to study. It's one of the things we're working on at UCLA with my partner and co-collaborator Shira Meliswarpu, who's a tissue engineer by training, and we're looking at how to develop these models, because that is, if we look at our colleagues in cancer, that's what you do, right? You create a cancer model in an animal, so then you figure out how to cure it. We're not there yet with Peyronie's because we don't know how to create the model. We just know what goes wrong. Are
there animal penises that are similar?
Yeah, rabbits do pretty good. Rabbits have a pretty good penile length to study, and pigs also. We're looking at certain kinds of pigs, and then rats. The typical rats for a lot of just the molecular study. But part of what we're looking at, just to maybe try to help answer your question, is we think that there is flex injury that causes abnormal signaling, what we call an inflammatory cytokine cascade. So basically, minding your own business, having wonderful, intimate, mad lovemaking, and somebody zigs and somebody zags, and it doesn't lead to a trauma where you hear a pop and you induce what we call a penile fracture, but it's more just this repetitive microtrauma that may set up this inflammatory cascade that over time, the penis is thinking, whoa, this guy's really doing some funny stuff down here. We need to make it stronger. So we're gonna suffer elasticity and go with rigidity of the fibers. And then that's when the change happens. And how it happens and how the genes that are expressed that cause that to happen is what we're really trying to study, because essentially we know that there are not only the genetics expression, but actually what proteins are expressed along those genetic pathways that lead to this abnormal fibrosis. And that's really where the interesting data is coming from. So that's what we have to figure out how to recreate in a rat. Now we can do it when I'm in the operating room and excising plaques, which is one of the surgeries we do to correct extreme curvature. I'm sending that tissue to Sriram, and he can actually do proteotyping on it to say what are the genes involved, but what is the expression of those genes, and then maybe come up with sort of a tissue bank of all of the different abnormal types of collagen that we see within these Peyronie's plaques, because they're not all the same. If they're all the same, then we'd have a treatment, and I'm sure we're going to get into drug treatments for this and intralesional therapies. Then it would work for everybody.
Right.
But simply not the case. So bottom line is microtrauma. And the second part of your question, that's super exciting, is how do you prevent it? And really we didn't have much of an answer until we accidentally ran into one of these kind of observational things a few years ago in our clinic. And it was actually my physician assistant, Keith Regetz, who does all of my post-prostatectomy erectile dysfunction guys. The guy comes in, he's getting a radical prostatectomy for prostate cancer. We know there are things we can do to prevent them from getting severe erectile dysfunction. One of those things is daily Cialis, taking daily tadalafil at a low dose, 5 to 10 milligrams. And in those cohort of guys, because he does all of my ultrasounds, he was saying, and he sees all these men in follow-up, he says, you know what? I'm just not seeing a lot of men after radical prostatectomy that have Peyronie's. And yet there's a great study from Dr. Mulhall, one of the legends in our field from years ago, I think I want to say 2006, that said actually one of the big risk factors for developing Peyronie's disease is radical prostatectomy. So you have a disease model where if we think about the general incidence of Peyronie's in the population, about 3 to 10% of men will develop Peyronie's disease at some point in their lives. And in our population, in the radical prostatectomy population, rather, it was like 16 to 20. And we just put this out about, I think I'm going to say about a year ago, and 300 or 400 men that we were looking at, 2%. So we actually maybe find something that prevents Peyronie's disease, which is taking a low daily dose of tadalafil. Kind of makes sense because Jake Rafer, another just legend and idol of mine and partner of mine up at UCLA, who was very, very instrumental in actually, bringing the little blue pill to science years ago. He noticed even in 2003 in the lab the antifibrotic properties of the PDE5 inhibitors like Viagra, Cialis, or sildenafil and tadalafil. So there's a link that, retrospectively looking, maybe that's what it is. Is it low daily dose of PDE5 inhibitors in men? But I can't tell you who's at risk for it either. I can't tell you, should every guy at, when they turn 18 just start taking, tadalafil to prevent this 3 to 10% possibility? That might be just a little bit overstretch.
Yeah. I think tadalafil has a lot of utility that still remains to be seen. Like I've seen it anecdotally in some guys with pelvic pain for a variety of reasons, also helps. There was a small study in men posterior urethroplasty that saw benefit in putting them on tadalafil after. I think it's just improving blood flow, which overall helps oxygenation of the tissues and a variety of things. But ultimately, that's really fascinating. But again, you're right. When do you start it if you're going to use it as prevention?
Right. Yeah. So, it's not necessarily associated with other things in any grand scale that other sexual dysfunction isn't already. So, example, men with diabetes, men with heart disease, men with hyperlipidemia, they all seem to have it's at least an association with Peyronie's. The one thing that also is compelling that gets thrown out there from some data Larry Levine did years ago was the number of men that have Peyronie's disease that also have hypogonadism, about 40%. And so that's one thing that if you are somebody that is noticing a curvature in their penis or a change in the structure of their penis and you're seeing a physician, I would ask them to throw a testosterone on just to see. That also sort of makes sense because testosterone is a inducer of nitric oxide. And nitric oxide, as you were talking about with blood flow and smooth muscle relaxation, probably super important to keep all those little collagen fibers happy and bathe the nitric oxide. And if your T goes down, then two things happen. One is you may not be getting as rigid of an erection as you used to. And so it could be that that little flex trauma is a little bit harder. So the guys that say, I used to be able to hang a gym towel on my penis with an erection. Now it's just not working, but it's okay for intercourse. There's somewhere in between the gym towel and how we age where maybe those Peyronie's fibers happen. And if you can keep a man at an adequate testosterone level, that actually may help improve their or may help decrease that risk. But again, that would be speculation, but certainly low testosterone, Peyronie's is a pretty strong correlation.
Yeah. And they may be at higher risk for those micro traumas, essentially.
That's right. Yeah. I mean, they just, it's hard to really know as men, as we age and the wheelhouse of men, the big demographic is men in their 40s to 60s. I've seen men as young as teenagers with Peyronie's and I've seen men in their 80s with Peyronie's. But when you think about it, when we start to see men with worsening erectile dysfunction, that happens in our 50s, 60s, and you really don't know if you have Peyronie's unless you're having really good erections, but you may be having okay erections for your 40 to 50s, and then it starts to wane. And that may be the time when we're starting to see that lack of rigidity leads to more flexion and more microtrauma.
Are you sick of going to the doctor only to have them talk at you for 15 minutes and leave without knowing exactly why they're prescribing you this certain medication and what exactly the next step is to take to optimize your health? Wouldn't it be great to finally find a doctor who actually listens to you, answers your questions, and doesn't rush you out the door? Well, at my practice, Rena Malik, MD, I aim to do just that. I specialize in taking care of patients who have issues with their sex lives, issues with their bladder, with their hormone health, or are having pain in their pelvic region or with sex. My goal is to give you the time and attention you deserve so you can leave with a clear understanding of your condition as well as our treatment plan that's optimized for your goals. During your visit, I'm 100% present with you for an entire hour. And after you leave, you can reach me. It is super easy to send me a message through our secure portal, and I'll get back to you within 24 to 48 hours. No questions asked, no hidden fees. Scheduling is easy. Just visit our website, renamalikmd.com/appointments. We see patients in both Irvine and Beverly Hills, California, and I see patients virtually in California, Florida, Illinois, Maryland, New York, New Jersey, and Virginia. Oh, and don't forget Texas. If you're outside these states, consider seeing me for an educational visit. I look forward to seeing you. One of our audience members asked, can vigorous masturbation, or are there certain sexual positions that make you more likely to have a microtrauma that may result in Peyronie?
Right. So, well, actually, it's interesting. I would like to take that question and open it up a little bit more psychologically. It's amazing how many things that in my office, I see men that they attribute to masturbation, or they attribute to something they did wrong. And I think the first thing I want to do is just get rid of any shame and any guilt around this condition, because you didn't do anything. It was not you. And in fact, we know there's a very high genetic predisposition to this condition, very high. And we've identified some of the genes that develop abnormal scar tissue, both in the penis, in the hand. It's associated with contractures of the palm of the hand called Dupuytren's, and also with contractures in the sole of the foot, the Lederhosen contraction. So we know that this is genetic. And if a guy gets a contracture in their hand, they don't sit there thinking, God, what did I do wrong? Who hates me? But yet, if it's in the penis, they're automatically assigning guilt, like I did something. So the answer is, it depends on how you define vigorous masturbation. The penis is a pretty amazing organ. I mean, it's resilient. And actually, if you think about the normal anatomic function of a penis, it does flex. And we have the MRI, that classic MRI data from the early 80s or so in France with an erect penis inside a vagina. And you see there's a curve. The vaginal canal actually curves the penis. So it actually is physiologic to have some curve, at least during vaginal penetration. Obviously, we don't have the studies of what it would look like penetrating other orifices, but I imagine it would be sort of the same. So no, masturbate as much as you want. Now, if you're breaking your penis with masturbation, if you're doing something vigorously traumatic, causing bruising or causing frank swelling or even blood when you pee, then that might be saying you probably have to slow down a little bit. So no, positionally, boy, that's a hot button topic. I knew it'd come up. We think that any time that a man is not in control of his thrusting may lead you to an increased risk of penile fracture. If penile fracture leads to Peyronie's, which it does in a small percentage of men, in fact, about 20% of men will remember exactly when it happened. And then, boy, talk about guilt. Then it's not just the guy, but it's his partner. So I see couples coming in all the time thinking, I just wrecked my partner's penis. And then, again, I say, you guys are just having fun and bad things happen. Sometimes you throw out your shoulder playing basketball. You don't feel guilty about it. We figured out how to get you better. But that really is the thought, is that anything where the guy is not in control is probably where it leads to those microtraumas. So the classic is any kind of cowgirling, because there's not only the woman often, or the top partner often in charge, but also that, at least in a heterosexual couple, the higher risk of hitting a pubic bone. So, so that's sort of the classic. But if you're going to ask me, which I'll answer for you, do I tell men they have to limit their positions based on some risk of Peyronie's? I don't. But one thing I would say is probably wildly drunken sex is not a great idea, because
or
then
wildly altered sex.
yes, or altered. You're right. I guess exactly right. Wildly altered unprotected sex can lead to, penile fractures, can lead to probably a lot of different traumas. And
there's a very famous celebrity who fractured his penis, I think.
Dennis Rodman.
Dennis Rodman. I'm like, what?
Yeah.
Yeah. So Dennis Rodman actually fractured his penis. Was it 7 times?
Something like that.
Something crazy.
Yeah, the lore keeps getting, but yes, that's exactly right. Yeah. So you have to have some degree of judgment, but right, it has nothing to do with practices. It has nothing to do with anything other than you have a predisposition, and then something else may or may not have happened that led to this.
So if you have a curvature, I think, at least in my experience, it can be at least the patients who finally make it to the doctor, right? Because there's many people who have it and don't come see us, but they're pretty devastated. And there's a big psychological toll. What, in terms of investigationally or in the research, have you found in terms of the psychological associations with Peyronie's?
Right. I mean, it actually goes both ways. So there are still men that I see with Peyronie's, and it's a good chunk of my practice, at least probably 40% of the time I spend in the office is in Peyronie's disease. I still every once in a while see a guy that comes in, has a lump in his penis, and wants to make sure he doesn't have cancer. So that's the first thing is reassurance, rule out, and make sure that he doesn't, because there are cancers, actually, not to scare your audience, that can lead to that. So again, only to admonish your audience, if there's a change in your penis at all, go see a doctor and we'll figure it out. But for the majority of men that are coming in and looking at just saying, yeah, I just want to make sure nothing is getting worse. It's fine. I have a mild curve. It doesn't bother me. But that's a minority. And part of it is there's a barrier of access in terms of getting to me in West Los Angeles and, probably waiting on my wait list to come see me. So most of the people I see are pretty invested in having that curvature. And then it is devastating, and they are devastated. And I did a paper it was in the Journal of Urology a few years ago with some colleagues from Karolinska. Martin Cederloff, I believe, was a senior author, and he's a psychiatrist actually in Karolinska in Sweden, and he had a database of almost 9,000 men, so huge database, and looking at the psychological toll that Peyronie's plays on men. And it's devastating. I mean, the use of antidepressants is 3-fold higher than the average population that does not suffer with Peyronie's. The risk of suicidality is 2-fold higher. So it's real. I mean, there are men that I can't tell you how many times in even a day will come in and say, Dr. Mills, I wish I had cancer. I mean, you could give me hope and cure this. This is worse. And I don't want to make light of any other condition, obviously, but I do want to say this is something that causes men to become shut in. They don't want to date if they're single. If they're married, they tend to be averse to engaging in intercourse with their partners. You cannot say enough about how devastating the condition is and how important it is to address that up front. One of the things as healthcare providers we have to be very, very sensitive to is that degree of psychological impact, because I see men all the time that are marginalized by their physicians. Even other urologists say, don't worry about it, or they make fun of it somehow and laugh it off like a locker room joke. And you always have to choose your audience. There are certainly a lot of men that come in and try to make light of it. Humor is a great way to deal with stress, as we know. But when you really get down to it, nobody wants this to happen to their penis.
No.
Of all the things that I know as a physician and all the things as a men's health expert, I know to stay in shape and to eat right and to not drink, or at least drink in moderation, and sleep and everything else. I could wake up tomorrow with this. Mm-hmm. Yeah. So it's a disease that we just don't have enough of an understanding of to avoid or prevent, unless we're trying to plug our 5 milligrams a day of tadalafil. But for the most part, these men are crushed.
Yeah, you brought up a good point about humor. There's actually a study that just got published. I think Justin Dubin is an author, and it talks about humor when talking about erectile dysfunction and how many doctors use humor when it comes to talking about erectile dysfunction, probably because they feel uncomfortable or they're trying to make the patient at ease. But apparently the patients did not like it and wanted a serious professional conversation. And I think that just underscores, again, for something like this is serious. And especially to the patient, it's really serious and life-threatening to their mental health. And so it's really important to make it a professional conversation.
I'm glad you said that. I'm glad you said life-threatening, because it really is. I mean, the mental health and the quality of life that men suffer with this, and potentially their partners, is huge. Mm-hmm. And right, humor it seems so easy. I mean, we have entire entire volumes of dick jokes. And so you can just, and so sometimes they're funny, but sometimes they're just not, especially in these situations where the guy is actually suffering from it. And so, as I said, if somebody comes in and leads with it and tries to make light of it, I absorb it, but certainly I would never give it back to them.
Yeah. I mean, they're just dealing with they're coping with their own stress.
That's
right.
Know?
I found that study, I think, and basically they also said that there was a higher risk of substance use disorder, alcohol misuse, and anxiety disorder as well. So really serious implications in terms of having Peyronie's and how it affects you. So if you're listening and you have a partner that has this, just realize that this is very serious. So what do you tell partners if they're with your patient in the office?
Well, first of all, I love it when somebody does come in with their partner, because it does allow us to have that dialogue. And as I said, I often say he's so lucky he has you, because the men that don't and that are suffering in complete silence and solitude is huge. And there are support groups, there are resources out for men. But boy, if they have somebody that's on the journey with them, it's incredibly helpful, because it is something that I can't imagine how to bring it up, with a new partner. Say, by the way, this is something that you may have never seen before, and dialogue is great, and making sure we have open lines of communication with our partners. But boy, it's so much easier for someone to be there. Sometimes people will lose their partners. I've even had men halfway through that their partners have left them when we're still trying to come up with treatment options. And so right, I say there's no shame here. There's no guilt. You didn't do anything wrong. He didn't do anything wrong. And we have to come up with a solution that works for both of you, whatever that is. And that really goes into this global or wider concept in medicine of shared decision making, and saying, I can offer you pills and pokes and procedures, and we just have to figure out which way. And also just observation, It could be. I mean, I've had partners say, I like him at like 20 degrees. Can you get him back to 20? And I have to sort of meet them where they're at and say, well, I'm not that precise. Surgically, I'm that precise, but with other treatments, not that precise. So it is it's something that is really wonderful to have them be part of that conversation, that dialogue.
So when someone chooses observation, are there certain tips you have in terms of having successful sexual encounters?
Well, I think like anything else, it seems like lubrication makes a huge difference. So I think I definitely counsel couples on adequate lube, so that they don't have areas where they could can have much more of a sort of a trauma or a dryness injury. So that's huge. And then position wise, as I said, is whatever you're comfortable doing. It can be very limiting, both from the length loss and just the way that the penis is curved. And of course, we have to understand that the world of sexuality is not just penetration. And so some couples are perfectly happy because they haven't had penetrative intercourse anyway. And so again, it goes back to, we just want to make sure he's okay, and that they're still able to engage in intercourse or in sex the way they want to engage in it. So again, I think it's really just having a really nice open conversation about what their expectations are, how they're currently engaging with each other sexually, and going from there. But other than that, no, I don't really. I think you just you use it and see what happens.
Let's talk about the length loss.
Yeah.
Let's set the stage. So when you develop a curvature, there's an active phase that can last up to 6 months or so, where things can change over time. And so how much length loss can someone expect? It
varies, like anything else. And the way that the penis is in general is that there is a true difference between men that show and men that expand with erection. It really is, and it has to do with the elasticity and the smooth muscle state and nitric oxide. So a lot of guys they're thinking length loss is the fact that they're just not getting that dangle they used to get. And so one of the things that we do when I examine men is actually do a stretched elasticity test and see, and that gives you kind of an idea of how much this is just poor nitric oxide, poor smooth muscle, and how much of it is fibrosis. Because there's some men I can examine where I will grasp the head of their penis and pull, and there's zero elasticity, nothing, and zero. And then others where even with significant curvature, I might still get an inch or two of nice elasticity. And that's a big part of my intake, is to understand that, and also a way to monitor therapies, especially if we're doing intralesional. So the answer is that some men have told me they've felt like they've lost up to 4 inches. I've had also men, and again, this is where people other physicians say, well, that's ridiculous. You can't lose length. And I mean, I can remember early in the days of intralesional therapy or in collagenase, probably like 2014, 65-year-old man that just, he really was getting gaslit by his doctors, and he needed peace of mind. He said, Doc, I think I'm crazy. I don't have a curvature, but I swear I'm at least 3 inches shorter than I used to be. What's wrong with me? And he just had his entire dorsum of his penis was all plaque. He just didn't have a curvature.
Yeah.
And he had Peyronie's, just a kind of Peyronie's where you don't get to see that curvature. But boy, I mean, he just needed somebody to say, no, this is not in your head. This is really happening.
Yeah.
This is terrible. We're going to figure something out for you. But it can be dramatic. And then some people don't really know or notice much of a length loss. But I think one of the things that is interesting about length in general is perception and perceived and functional length. So when we talk about therapies for Peyronie's, one of the things that has been around for over 100 years is what's called a penile plication, where all I do is go in and I just straighten the penis with a few plicating stitches to kind of reverse engineer it back to where it used to be. And one of the risks that we think about is that you can lose length. Al Morey, who's another titan in our field, says, well, I always talk about functional length loss because right now your functional length is 0 if you can't have intercourse. And so what I'm trying to do is restore functionality by these surgeries. And I think that's a really good way for patients to grasp the idea, because that's just a deal breaker. If you come in and say, look, I can make your penis perfectly straight, but it may not be as actually long as it used to be. It definitely won't be as long as it used to be prior to suffering from Peyronie's. We're just trying to get you functional again, setting the expectations, but also understanding that length is relative. If you can't use it at all, then it's 0.
Yeah. It is a serious perception change, but it is real for sure. As you described, the hourglass deformity is a type of Peyronie's disease where you have plaques that create sort of a different shape of the penis, and that can cause length loss. So I'll see patients sometimes where they'll notice that their erection quality changes beyond the plaque. So they'll have the plaque, and then beyond it, they're like, it's just not getting as firm. It's just not getting as robust as it used to. So how do we manage that?
So we call that distal flaccidity, and we, first of all, educate the patient. It's amazing how many patients think that their glands should be rock hard. And some things, you change, the perceptions of anatomy change. When you really key in on your penis, you notice things you never noticed before. And one of the things is that the head of the penis is always a little bit softer than the shaft of the penis, and that's physiologic. That's how we keep blood flow and perfusion. And so I have to make sure they're not just saying, my glands isn't hard anymore. And I swear it used to be hard, and it really hadn't been. But again, your perceptions, you're keyed in on this. But what we do know is that if that plaque is impinging on the vessels in the penis that provide the erectile tissue all the way out to the head of the penis, then it can clamp off blood flow. And we've done this with ultrasound, where you'll look at the proximal or the part of the artery close to the base of the penis, and they have great velocities, super amazing. And then you hit the plaque, and then after the plaque, and all of a sudden they drop in half, and you really end up with sometimes what we refer to as a hinge, where the blood flow just stops because the plaque is so compressing on the arteries, the cavernosal arteries, that you don't get any blood flow past it. So that we got to fix, and a couple different ways to do it. Again, some of it is based on how bad it is and what men are willing to go through. That's something that surgically you really can't do anything other than remove the plaque and remove that lesion. And I do penile ultrasounds on men pre and post plication, by plaque excision graft surgery, because I want to see if those vessels open up. And obviously they'll tell you too that they're getting better erections. But even with intralesional therapy, if you're decreasing the volume of that plaque, you can start to see it relax, and you can start to see blood flow come back. We have a very small paper out years ago, 2019. I think it was one of my fellows, Andrew's son, is now down in Dallas, who looked at post hourglass or post atypical deformities and saw the velocities did improve after Xiaflex, although a couple other papers in the literature say they didn't see much of a difference. So, again, we have very small numbers to know, but I do think there's a signal there that if we can figure out how to restore blood flow distal to that plaque, that we can restore some of that distal flaccidity.
Do you think daily tadalafil helps with that? It
does. It doesn't hurt, but the tadalafil it's a molecular working drug. It works on the smallest little enzymatic pathways. And so, if you have this giant chunk of granite that's pushing down on the arteries, then you're not going to see so much improvement with it. But it structurally helps everything else. So absolutely, it's almost everybody leaves my office that has a diagnosis of the Peyronie's with a prescription for daily tadalafil.
Yeah. I think that's great. So I think one thing that I mentioned and we learn in training is, that during the active phase of Peyronie's where things can change, you shouldn't do anything. So I saw you wrote a recent paper on, or at least a public abstract on, that we can do things during the active phase. So let's talk about that.
So yeah, this is science at work, and it sort of damned, I guess, a number of men for a while, because when we did the Impress trials years ago, so I got involved in phase 2, so around 2006, 2007, in science, you don't want to have multiple variables going on, right? You want to change one thing. So we excluded men that had acute phase plaques, because what if their plaque got worse? It'll make the drug look worse. What if it got better and make the drug look better? But either way, it's another variable that you can't control for. And so that's why we wanted people to have a stable plaque for greater than a year. Physiology, however, completely independent of the science. So the physiology is if you have scar tissue and it's still in that early phase where it's not completely turned into this very super fibrous, dense, or even calcification within the penis, we said, maybe that's actually the time to do something, is to treat these in the acute phase before it gets worse. That's good for 2 reasons. One, maybe there's a molecular reason for doing that we're able to disrupt those collagen fibers before they really, really get nasty and dug in. And 2, you're not telling a guy, hey, I'll see you in a year. Mm-hmm. He's coming in with a devastating psychological condition. And you're like, yeah, just go start fishing or playing basketball or something else, and we'll see you in a year. Yeah. You can't do that to somebody. And so that's why it's not off label to do that. I mean, one of the things about the Clostridium drug is it's a very expensive drug. You have to get authorization for it. There's nothing on the label that says that we can't inject in the acute phase. A lot of insurance companies say, well, it has to be a stable plaque for a year, because that's how the Impress study that got this to market worded it, because of what we just explained. But nothing's saying we can't do it. And so thankfully, a lot of with some peer-to-peer reviews, we're able to get enough people authorized to try it. And right, it looked as if it works just as well. Which again, if I wanted to oversell this, I would say, well, yeah, but if they were going to get worse and we did in the acute phase, then maybe it actually works better, because you got a guy with a 30 degree that's going to end up at a 60, and you give him 20, then maybe you actually made somebody go from 60 to 20. And the most important thing, you didn't make them wait a year to get there. So I think I don't want to say standard of care, but I think should be standard of care to consider early intervention. The one thing you don't want to do early is surgical correction, because you got to let that thing play out. You can overcorrect. I'll tell you kind of a shame on me story, a very interesting situation in somebody, a younger guy that presented with a pretty aggressive malignancy, and he had just incidentally had a pretty significant Peyronie's, and he was devastated, couldn't have sex, didn't have amazing life expectancy, but not bad. And I fixed it. I placated him. Really proud of myself. It worked. But he ended up continuing to get curved. I underplacated, and he still ended up with a curvature that we still had to fix. So I probably jumped the gun on there for maybe more compassionate reasons and not scientific reasons. But the surgical correction, you got to let that thing mature a little bit more to know exactly what you're dealing with, especially if you're going to do a plaque excision and graft, which is kind of the mother of all Peyronie surgery. Yeah.
We'll get into all of that. Before we get into injections and surgery, let's talk about conservative options. So, earlier data, there was a lot of oral options. There was a lot of things that you could try. Are there oral options now that you recommend?
Yeah, the only one would be daily Cialis. We've tried things over the years from Potaba to tamoxifen, colchicine. Pentoxifylline is probably the one that had the best data over the years. Tom Liu was a legend up at UC San Francisco. I did some pretty compelling work with, observational work with pentoxifylline. It makes sense. It's an inflammatory cytokine inhibitor. And so if you look at the initial pathophysiology we're discussing, penis senses it's upset, it has an injury, it starts sending all these cytokines down to make a scar. What if you could give them something to prevent the body from putting a scar down there? And that was the rationale for pentoxifylline. And it showed maybe 30-40% efficacy in certain men, and it had to be in the acute phase, which again makes sense because if it's mature already, those cytokines are long gone. They've cleaned up their scaffolding and went on to the next construction site, so they're not there anymore. But the acute phase, maybe it works. So I'll offer that. Our guidelines for the American Urologic Association say, really no oral medication has any degree of evidence that it works. But some men want to try something and they don't want to get aggressive with their therapy. And so most of those things are harmless, and most men tolerate pentoxifylline fine. So I'll offer it. We call it our antifibrotic therapy. A lot of us will throw in citrulline or L-citrulline, which is an amino acid that is easily converted in the liver in the kidney to nitric oxide. And so maybe you're increasing the substrate with citrulline, and then you're blocking the breakdown with tadalafil, and then pentoxifylline actually works on a totally different cascade. So that works. Some guys do fine with it. We don't know. About 10% of men will spontaneously resolve, and the acute penile traumas tend to do better. There are men that really will break their penis or almost break it, not to the point of maybe going to your or my operating room to fix, but at least to the point where they know they had a spot, they know they had bruising, and those can just get better because they have normal wound healing and they just hurt themselves and it got better. So maybe you're missing, or you're including some of those men in the pentoxifylline arm that we're going to get better on their own anyway. So I don't really spend a lot of time with conservative therapy, but I offer it. Yeah, for sure.
Yeah. And so when someone comes in the early phases, what do you tell them? What's their chance of getting worse?
There's no great studies to show this. There's some of the earlier studies from the 1970s that said it was a third, and a third, right? Mm-hmm. So a third get better, third stays the same, a third gets worse. And we know that's not true at all. And so nowhere near a third get better. And most of the time in the acute phase, they will notice a pretty dramatic change. They could wake up the next morning and have a 45-degree angulation, and those men, they tend to stay in that realm. So what they get acutely is what there is. And so I don't typically quote them numbers because, again, I'm really against just saying just go home and don't do anything about it. Almost everybody I would at least offer some kind of oral therapy, and I don't do any of the transdermal therapies that are out there that people are selling for stupid amounts of money for topical verapamil. And there's a really great, really elegant, again, quote John Mulhall on this study where he put topical verapamil on men, took them to the OR for their plaque excision and graft, and then sent the plaque, and there's zero verapamil ever gets anywhere near the plaque, right? So the transdermals there's just no real good evidence that they work at this point. Very expensive, but they're looking at new emollients, looking at new ways to do it. There's some interesting subcutaneous thoughts that if you could get it under the dermis and some of these long-acting subcutaneous reservoirs, that's kind of cool. I'm kind of interested in that, but nothing really even in a phase 1 study yet. But those are things that my mind thinks about, is if you can get something under the skin that just sits there in a reservoir, then slowly elutes, maybe there's something to that. Yeah,
that is interesting. What about shockwave therapy?
Yeah, so I think the data on shockwave are compelling now for erectile dysfunction, for upregulation of smooth muscle, and so I think that's probably going to be very close to being more widely accepted in the scientific community. It's been offered, as you know, for 20 years or so. In the Peyronies, I never understood the mechanism. Right? If you don't understand the mechanism, then it's hard to promote something. The one thing I would have a shockwave that I'd be very interested in is and again, this would all be experimental, but if you combine shockwave with something that actually effects change in the plaque.
Mm-hmm. Yeah, because the shockwave would be like the daily tadalafil, maybe.
Yeah, you're right.
The same sort of...
Exactly. And shockwave does have, there are pretty interesting data in the orthopedic literature about it. Promotes wound healing, promotes upregulation of tissue healing, right? So great, but I don't know that we can go in and shock a mature plaque and make it go away. So you need something to make the plaque go away and then potentially shock it. And that's interesting, and that's something that I really want to look at more. I mean, I know anecdotally there are men that are doing intralesional therapy and shockwave, and I think if we can get a nice trial together for that, I'd be super excited to see that, because I think right now the world of shockwave is there's a lot of fascinating research being done, a lot of it in Europe, that I'm very excited to see where it goes, not just in erectile dysfunction, but other urologic issues and chronic pelvic pain, for example, which you know a lot more than I about.
Yeah.
But I'm super excited in the microbiome changes. So yeah, no, I'm definitely interested, very interested, but I can't quote you a paper yet.
Are there other things like transdermal, whatever, verapamil, or other things that are being marketed to patients that are not necessarily effective?
There's another newer molecule that's out there that has a better. It's basically just nifedipine, so it's just verapamil with a different emollient, and it the idea is that maybe it gets into the skin more, but again, we've never done a study. We need to see, will that emollient allow this molecule to get further in, and it's still a calcium channel blocker, so it's still just a generic, a different form of verapamil.
Yeah.
But,
I mean, the transdermal penetration and then through a plaque, that's hard. That's really difficult.
It's hard. You got to get through the neurovascular bundle. I mean, there's a lot of real estate between the skin and the plaque. Yeah. And then, as we were saying, plaques are heterogeneous. They're not all just chunks of collagen. There's calcium deposition in it. There's a lot of other. It's a very, very wild west of inflammatory proteins in there, as Dr. Ellis Warpu's studying. So yeah. So I think it's just a salve. It could be purely the fact that when you're putting in anything topically, you're rubbing it in, you're maybe doing a little modeling, and that modeling of breaking up the protein. Because we know that if just even that mechanical changes in traction from both the IMPRESS study as well as penile traction devices, it may seem to do something. So maybe if you're really vigorously massaging a topical in there, you can be, putting anything on it, but it's the mechanics that's doing the heavy lifting.
So let's talk about modeling and traction devices. What is modeling, and how can patients do it safely?
Modeling is purely just stretching the penis, mostly in the flaccid state. And the way I describe men to do it is to just grab the head of their penis and pull until it hurts at the base of their penis. Our penis is held to our pubis by suspensory ligaments, so you can't just keep pulling it. And so pull it until you feel those ligaments engage, and hold it there for about 30 seconds and relax, and do it again at least 3 times a day. And all you're doing is you're trying to longitudinalize those plaque proteins that are abnormal, and maybe training it to go in the direction you want it to go. The second part of modeling is to just flex the penis in opposite the direction that it's bent. So if you curve up, you put your penis on the bottom side of your penis and pull down right as wherever your curvature is greatest. So that would be your fulcrum. And again, as part of an intralesional therapy, modeling works. Modeling independently has pretty good data. Traction is kind of passive modeling, where you set it and forget it, and that is multiple different traction devices on the market from $30 to $600, and essentially all you're doing is wearing braces for your penis. So the idea of traction is that constant strain on those proteins is actually modeling or changing the fibroblast infrastructure, which is what sets down the new healthy collagen into a more linear pattern, so you're not getting that scrambled egg plaque of what a collagen protein plaque looks like, and just kind of elongating it and getting it back. Also, for those people that are interested in it, which I know is a small subset of your population, it can improve penile length too. So there is something to that. And the question is, how compliant do you have to be? How long, is it like anything else that's physical therapy? You get maybe 2 centimeters of your lost penile length back, but are you doing this every day for the rest of your life, or can you do it for 3 months and it stays? And really, really don't have amazing annual data on this.
Yeah. I agree. I think that traction is great. It's safe. It's pretty easy to do, but it does require sort of a commitment, and maybe a long-term commitment. We don't know. Right.
Yeah. And I think the only thing I do have I have some concern around traction and combining it with intralesional therapy, just because of the bruising, swelling that can happen. I definitely have had men that have felt a lot more discomfort with traction, even had some skin breakdown. So you have to be really careful with that situation. And guys, some people overdo it, right? Yeah. And if you say do it for a half hour a day, they'll do it for 7 hours a day. And then you can get some nerve stretch, a little bit of neuropraxia where you get a little numb penis. So right, very safe if Used as directed.
Exactly. Used as directed. Yeah. Are you feeling in a rut in the bedroom, wishing you had the kind of sex life you could brag about? I've spent years helping patients and creating content for people all around the world to improve and optimize their sex life. Today, you can get my knowledge for 100% free with my new ebook called Better Sex, Better Life. In this ebook, I review my top 10 tips for improving your sex life, all from the comfort of your own home. All you have to do is go to renamalikmd.com/morepleasure to download it for free today. One of my audience asked, when you have erectile dysfunction and Peyronie's, we counsel patients. Sometimes you can do something like intracavernosal injections of medication. So can that cause another plaque, right? If someone is already at risk for getting these plaques, can that cause another plaque? And if you don't have any plaques and you're just a regular guy, like, because you're potentially injecting usually around the same place every time, are you at risk as well?
I love this question because I don't understand it. When you look at all of the risk factors for Peyronie's, it comes up over and over again in intracavernosal injections. So you're sticking a vasoactive agent into the corpora cavernosa, not into the tunica. And this is sort of a pet suspicion of mine, is that when men, and again, this is sort of in the older days, a lot of this literature comes from before even the PD5 inhibitor days. So here's a therapy, brand new in 1981, 82, 83, where men that had not had an erection for decades could go to their doctor's office, go to the corner store, essentially, in some of these pop-up shops, and get an injection. And then all of a sudden, they say, whoa, my penis is curved. Well, maybe it got Peyronie's 10 years ago, and now this is the first erection you've seen to know that you actually have a plaque. So I don't know. I mean, I definitely see a lot more corporal fibrosis with intracavernosal therapy, where the actual penile tissue, the erectile tissue, with repeated injections in certain men will develop thickening. So I don't know truly how much of a risk factor it is for developing Peyronie's as it is just for the fact that you've had a fallow penis for a long period of time, and the first time you got an erection, whoa, here it is. Having said that, I still think that intracavernosal therapy is amazing, and I have men that have been on it for decades, and I love doing penile implant surgery. I do a lot of them, and I think it's an amazing operation. But I never sell a guy on a penile implant before I say, hey, look, if you're cool with this, have I got a medication for you? It's like $2 a shot. It's really safe if we get the dosing right. I'm going to teach you how to do it, and you're going to be off to the races. Then you do that. What's the worst that can happen, doc? Well, you could develop scar tissue, and you're going to need a penile implant. But right now, if the pills aren't working, what are our options? You're going to need a penile implant.
Right.
So that's sort of how I look at intracavernosal therapy. If they develop a mild curvature as a result of just age and genetics and all the other things we discussed, and we'll deal with that later. But yeah, I like ICI as a great therapy for the right person.
Yeah, I agree. And the needles are really small, so it's the trauma to the tunica is like nothing. Right. So they're really small needles.
Yes.
Let's talk about intralesional collagenase.
Yeah, let's talk about this interesting enzyme. So collagenase it's a flesh-eating bacteria, and it comes from a Clostridium biomolecule, so it's a bacteria, and its job in the bacterial setting is to just destroy collagen so that the infection can spread right through any part of your tissue, any part of your body that has collagen. What has a lot of collagen? Your skin. That's what makes it nice and bouncy, and as we get older, not so bouncy when we lose collagen. So collagenase is amazing. It just rips through. But not all collagenase is the same. If anybody spent any time in a basic science lab, you can just pull it off your shelf and make it up for any one of your experiments to render proteins. So you're looking for the DNA you're looking for. You throw some collagenase in, get rid of the protein, there's your DNA. So collagenase is multiple different ACEs, and anything that ends in ACE is just an enzyme. And so the thought behind this actually goes back to a good friend of mine, dear friend of mine, Marty Gelbard, when he was a resident at UCLA in the 1980s, who his resident project for the year, for the research year at UCLA, was thinking about this collagenase in Peyronie's. He was very interested in it, which at the time very few urologists were, but for some reason took a shine to thinking about this condition that was really an orphan condition. And he knew the plastic surgery guys were using collagenase for scar reformation and seeing if it can soften cutaneous scars. And he said, well, geez, that's what Peyronie's is. It's a scar. It's in the penis, but it's still a scar. And that sort of led to the groundwork for a lot of research that then eventually led to knowing exactly what types of collagen are most in a Peyronie scar, is type 1 and 3. So the idea was that can we make a collagenase that's specific for type 1 and 3 so that if we inject it in a penis, it doesn't just destroy the skin and everything else around it. You want a very targeted enzyme. So if you put the thing in your science lab into your skin for the cheap collagenase, you're going to end up with a lot of collateral damage. So this is really an engineered molecule. It's a targeted molecule made up of the two most predominant proteins in a collagen plaque. And essentially the idea is you put collagenase onto type 1 and type 3 collagen, it disappears. It's gone. You can take it in a petri dish. It's amazing. It'll be gone in 45 minutes. Doesn't work that well in humans for a lot of reasons we're still studying. But at this point, after 30 years or so of research and data and drug development, that's when collagenase for intralesional therapy in the penis was approved in 2013. In 2008, it was approved to dissolve the collagen-based plaque in the hand for the Dupuytren's. And that's sort of the quick history of collagen therapy or collagenase therapy. And it really has changed the entire face of men's health. When I trained mostly as an infertility microsurgery specialist who did some Peyronie's, did some erectile dysfunction, but mostly, my future was going to be in infertility. And thankfully it still is, and I still do a lot of infertility work. But over the years, I've developed a very robust Peyronie's practice, in no small part just because of the research I did that led to the development and FDA approval of this drug. It has truly changed lives of many, many men. Mm-hmm. And it's great. I mean, some men will have complete resolution of their scar and curvature, but it is also, as I said a few years ago, I was interviewed in the New York Times and probably made everybody at Endo who makes the drug cringe, said it's not a super drug. I mean, it's still, not 100% effective. Mm-hmm. It's better than anything we have. That was 10 years ago. There's nothing even in the pipeline. So this is still the only game in town, and we're getting much better at injecting it. We're getting much better understanding protocols to even further improve our outcomes. And so again, still a huge game changer, still an amazing therapy that doesn't have a huge downside. And it's still minimally invasive, it's non-operative, and can go back to work the same day. So yeah, it has a pretty fantastic safety track record for improving curvature. But if a guy comes in with a 90-degree curvature and thinks he's going to be perfectly straight with collagenase, I tend to disavow him of that and try to set realistic expectations. But the majority of men that go through, at least in my practice, we have about 80% of men that get one round of 8 injections are happy. They're satisfied. Doesn't mean, and again, this goes back to patient bother, not necessarily angulation and curvature. I want to know if you're happy with your treatment and if you're happy with your penis. And if your partner's happy, to me, that's a win. And that's a pretty effective medication.
So how do you set the expectations? 8 treatments over how long? How much modeling are they going to have to do? And what is the average expectation?
First of all, it has to be, you want to make sure you're going to a place that has a very good team in place, because this is a big ticket item drug. It's not cheap. And so authorization is incredibly important. Most insurance companies carry it, but you want to go to an office that deals with this a lot so that you get authorizations, you don't get surprise billing. There's also patient assistance for it. So men, if they have an out-of-pocket expense, there's a number of patient assistant portals that men can go to get some of the offset. And so that's the first thing I do is set the financial expectations. Then I say that what's going to happen is you're going to get 2 injections in a week. Most of my men come in on Monday and a Thursday, and then you're done with me and the 405 and the traffic to get to my office in 6 weeks. And then you come back and you get 2 more injections. And so it ends up being a course from the minute I start that injection to the last 8th injection. It's about a 4.5-month course. It's not all active. I mean, they're in my office for really minutes of that time. We have a pretty good system to make sure we're not making people wait too long to do it. And in between, I have them start modeling right away. Now, again, I have to say some of what I say is not on label. It's really experience. I don't inject the way that the label says to inject. And I tell all my patients, I'm going to treat you exactly how the drug was developed, but I have some nuances and modifications that I found have worked better with pretty good clinical data at how we do it. And so one of the things is I have them modeled pretty much immediately. We set the injection, and even that day or the next day, I have them stretch for at least 90 seconds a day. And then I have them come back in the next 2 to 3 days. We do it again. And then, I want them to go to town. One of the other things that is critical to bring up, and again, off label considered, the hurdle for a lot of men is on the label. They say, well, doc, I read this and it says I can't have sex for 4 weeks after this. And that's a kind of a deal breaker. And that's a long time to say, okay, you're going to give me an injection. And then I wait 4 weeks. So I have basically 2 weeks of sex before I come back and get whacked again and then get out of commission for 4 weeks. And that was based on some pretty weak data that came after label. So phase 4 studies showing that there was one reported penile fracture with intercourse at about 3 weeks. And so out of an abundance of caution, which I'm delighted that Endo did, they said, look, we want to be sure. So we really want people to refrain for 4 weeks. Now, you're going to get erections during that time period. You're going to wake up with erections, and you have almost as much risk of fracturing your penis just from an erection at night and you roll over in bed funny than you are with very well lubricated man with penis in control of intercourse. And so I tend to be a little bit less dogmatic about that. And I know most of my Peyronie's colleagues that do a lot of injections have also gone a little bit away from that, because that is sort of disruptive, and then really no good data that you're doing anything differently. And in fact, with some of the aggressive modeling protocols that are making the rounds now, you're essentially doing way more trauma to the penis and maybe getting a better outcome. So in some ways we might be too gentle, and sex might be a good part of kind of physical rehab.
That makes sense.
Yeah, in a responsible, way.
Yes, well lubricated, in control.
There you go. I like it.
And then what degree of curvature reduction can someone expect?
This is where I hate statistics and quoting, because if you get a full reduction, then I'm the best doctor ever and this is the best drug ever. And if you get 0, then this drug sucks and you just wasted my money and time, Mills. So what the heck?
Yeah.
And so I tortured a medical student a couple years ago. He was amazing. Sadly, he went into ophthalmology. Maybe it was my fault, but he was a great guy, and he's going to do well. I'm talking about you, Reza, but I made him do this giant multivariate analysis and look at all of the things that go into our database for how somebody's going to respond. Presence of diabetes, length of plaque, degree of curvature, all of this stuff, to see who's going to be the guy, who's going to be that super responder. I want to come in with a nomogram. I want to be able to examine a penis. I want to be able to say, you're this, and here are the characteristics. Your curvature is this way. This is what your ultrasound showed. You're going to be 50% better. I'm going to take your 50-degree curve, make you 25. It's going to be great. Or if I see a guy who comes in, has really dense plaque, and say, you're probably going to be closer to 25. Really, we just don't know who's going to be a great responder. And I've been surprised. I've been so surprised over the years. Let me tell you a story of a guy. He was very inside healthcare. I think he was a healthcare administrator. And he came to me. He wanted to be in the phase 3 study. He's read about it. He was on all the trades. And he said, I want to be in your study, Mills, enroll me. He had a calcified plaque. So I did an ultrasound. When I do lectures on this, I'm sure one of them's online somewhere. And I show his ultrasound and his X-ray, plain film X-ray. He could see bone in his penis. That's how bad the plaque was. But he had some collagen around it as well. It was a heterogeneous plaque. So he had some calcium and collagen. And I said, you're excluded. I can't. I'm so sorry. I can't do this. But calcified plaques are excluded from the trial. So December 13th, 2013, that's the day that Xiaflex was approved by the FDA. January 3rd, he was in my office saying, it's time. I'm ready. We're doing this.
Yeah.
Didn't want surgery. He had a 75-degree curvature. He got down to 40 degrees with Xiaflex with a calcified plaque. He was a guy that you would say, no way. But he did pretty well. So I still inject men that have calcified plaques. I just don't inject the calcification part of it. So that part of that is really targeting it, getting to understand either with your tactile feedback or even with ultrasound to know where to avoid. You can inject a calcified plaque. It's bone. You're going to break a needle, God forbid, inside that plaque. So you have to be really careful and inject the part that's going to win for you. And so even those men have a good recovery. I've had other guys had the tiniest plaque. I've had guys that the plaque is totally gone and they're still curved. So again, that just goes to show that we just don't know. So if somebody is amenable to the time it takes, that's the big deal. So I say, look, you may or may not respond to this. You've been dealing with this for 1 year, 2 years, 5 years. And if you want to be better for a cruise in 3 months, we're going to go to the operating room and we're just going to fix this for you. And here are the risks and benefits of that. So that's sort of the expectation I set. But the number of men that I've operated on after XIAFLEX is pretty small, surprisingly small. When I see 1,200 at least guys a year with Peyronie's disease, and I'm still operating, I do 1 or 2, probably 3 or 4 Peyronie's disease surgeries a month, but I do many, many more XIAFLEX injections than that. So I still think the majority of guys do better. It just depends on how you define better.
Do you think those people are not getting surgery because they're better or because they just never wanted surgery?
There's 2 things I would tell you that to poke a hole in my statistical analysis. One is right, or did they just get frustrated and were they never surgical candidates in the first place? That not too many. I mean, it's a minimally invasive surgery. I can do a plication under a local, so I don't think it's that. And most of the guys that I'm doing XIAFLEX on have pretty good erectile function. I'm not doing it on guys that aren't getting good erections, so we don't think that's it. There are guys that may just get frustrated or live so far away from me that it's not worth coming back. But no, I think most of them are probably getting better. We tried to look at that and do some long-term follow-up, and maybe we'll have some publications soon to show you what that denominator looks like. But no, I think most of them are okay with how they're doing and relatively satisfied. But again, the ones that aren't and do surgery, it doesn't seem to make the surgery any more difficult. And sometimes I think I've seen men that would have been a plaque excision and graft, maybe 75 degrees, that I could get away with a plication. And so there are certain cases where it may help prime or stage them. But boy, it's a time commitment. I mean, I can't underestimate that and tell that these men are 4.5 months to get 10-degree improvement and then still do surgery. That's why, a lot of times we just go right to surgery. Yeah,
it is a time commitment. Is there an improvement after the first injection and after each injection, or do you have to stick it out for the 4 months?
Yeah, there is it's a scatter plot. There was an early study by Faisal Yafi and Wayne Hellstrom, I think when he was still his fellow, that showed that if you didn't get much improvement after 3 rounds or 6 injections, you weren't going to see much on the 4th. That caused a lot of people to drop off, interestingly enough. But I haven't seen that. And then actually, I think in the phase 4 studies, a year after therapy, people were still getting some improvements. And I've seen that in about 20% of men that we do a round of XIAFLEX on and they're not better and we bring them back. I used to just kind of march right along, get the authorization and say, come back in 6-8 weeks and let's just keep doing these for these big plaques. But partially, again, this is an accident of how busy I am that they can't necessarily come back in that time. And there are men that report that they are actually getting better. They're not as bad. In fact, I, not too long ago, maybe a week or so ago, had a guy, great, he could have called. He lived in the Central Coast, right? So 3-4 hour drive. And he was there for a second round. Sat in my office, the needle was there, he was ready to inject. He said, yeah, I'm better. I'm good. I just want to make sure we don't need to do this anymore. I thought, you could have called. You just get 8 hours, So yeah, I mean, I think my new protocol is to give it some breathing room in that enzyme and just the stretching. There's still some plasticity that can last well after that last injection.
In terms of surgical options, so you mentioned plication and excision and grafting. Let's talk about plication. I think the biggest concern with plication, as you described, is taking putting these stitches in, multiple stitches in to straighten out the curvature, is this fear of penile lengthening. And in my experience, when you mention that there's a chance of penile lengthening, the large majority of guys are halfway out the door. So how do you sort of handle that?
Well, I will actually say that I'm surprised that the biggest complaint I get with the plication is that the men really don't love the stitches, the permanent Ethibond stitches. I use a 2.0 Ethibond, I think most of us do, or a Tacron or something. And And I've been putting extratunical grafts over that. I'm trying, doing really, and I go all the way down to fascia. So I bury it, or all the way down to tunica, and I bury it under fascia. And so people are like, are these little lumps going to go away? And remember we had this discussion before that that is the surgery. That's your scaffolding. And so length loss, I think you can mitigate pretty easily with doing smaller stitches, taking more than just one giant.
Yeah.
And again, Al Morey's just really done some great work on that. And so the classic sort of modern day Peyronie's plication is what Tom Liu described as a 16 dot, where you take a marking pin and you literally make 16 dots, and one stitch is 4 of those dots. So you basically put 4 dots in, or 4 stitches in, and that is probably where you saw a little more length loss because you were scrunching it up too much. Maybe you got a little more inflammation, but something about these littler bites and doing a few more. But again, then they feel the stitch. So you just have to be really clear. And it's really also on the younger men that we plicate, and men that don't actually have Peyronie's but have congenital mismatch, where they have a lateral curvature from one corpora being bigger than the other, just like some people have a size 11 and an 11.5 on the other foot. You can get corpora that are mismatched and a bend, and really there's nothing. You can't Xiaflex that. The only thing you can do is to correct it, but those stitches can be pretty annoying, so I would love to figure that out. But yeah, the length loss I try to borrow from my good friend Al again and say, look, I'm giving you your functional length back. And I do like to use traction post-op in those men. I think it helps them rescaffold straight, and it does improve the elasticity a little bit.
Yeah.
But in general, the men that have zero elasticity, when you do that elasticity test, and when I'm pulling that penis and it's not going at all, I tend to lean more towards the plaque excision and graft. And one of the things that I've developed over the years as a way to spare a lot of their natural tunica. I used to just cut out everything, but there's usually a plane where you can get out the diseased tissue and then you still have the overlaying tunica, so you're not putting in as a bigger graft. It's a lot more tedious surgery for one that's already very tedious and long, but I don't think they contract as much. So I definitely have been doing more plaque excision and grafts than plications. And a part of that is because, as I was saying, a lot of plications are cured with Xiaflex. So you don't need to do it, because they tend to be milder.
Quick break from this episode to let you know I am so grateful that you're spending part of your day with me. I started creating content online to empower people to learn more about their bodies without needing to go see a doctor, pay a copay, wait in a waiting room, or find parking. And it has been one of the most rewarding experiences of my life. If you want to help support our mission of providing free education, please consider joining our premium membership. There you will have access to ad-free episodes, which are released early, as well as free transcripts and the opportunity to ask me anything. And these questions are answered in our monthly AMA episodes. Support the show and join today at renamalik.supercast.com. Can't wait to see you there. In terms of plaque excision and graft, there's been sort of a change in our, I guess, more recently using collagen fleece or Tacosil and incising plaque so that there's less tunica loss, and it's a little bit of an easier surgery, a little faster. What are your thoughts on that?
I'm going to claim ignorance on that. I cannot get it at UCLA. Yeah, okay. And so I know I have former fellows that use it, and I know the literature around it very well, and it seems very compelling. It definitely cuts down on the sewing, but I don't know, long term how it holds up. I know I had a colleague in Europe that has, again, one of my Swedish colleagues, that has not had great outcomes with Tacosil using it, and he's a very good surgeon. So I think it must be patient selection in terms of what you can get away with.
Yeah.
But I do think a plaque incision in graft where you're not removing that much and just making the relaxing incisions and putting in small grafts, I like that technique as well. And I think that does allow you, for a non-calcified plaque, to get away with link preservation, angulation, and you're not doing as much trauma. You got to spend a lot more time elevating neurovascular bundle all the way because you're making a much bigger arch to do that. But for those long dorsal plaques that cause more of a gradual deformity, those do well with those mini incision and mini grafting, and I think that's a great way to go for those. But yeah, for the big calcified plaques, I would love to keep as much native tunica as I can, and most of the time we're able to. It really is a day when the urologist becomes an orthopedist. I'm using orthopedic periosteal elevators and sometimes even a bone saw to get some of that bony plaque out. But man, that really is a much nicer, less morbid surgery for those men to go through.
And in terms of complications, the thing that we're taught in residency is erectile dysfunction is very, very common after the surgery. What is the true incidence of that?
I think it was Jerry Brock that did that great study years ago, that I do tell patients that after 5 years, the plaque excision graft guys, at least 50% of them will have erectile dysfunction. After 10 years, most of them will have some sort of ED that may even require an implant, it's at least injection therapy. And I don't think that's just, that's time too. You're not doing PEGs on 12-year-olds, right? You're doing plaque excision grafts on 60-year-old men or 55-year-old men who are then 65, and then they got a whole other host of comorbidities catching up to them in their endothelial function. And so it's not probably just that. So I think it's for me, it's the immediate 1 to 2 year, what's happening? Did I do something to cause alteration in blood flow? Did I do something to cause, which is the other dreaded fear, is a neuropraxia, where you injure or at least make the nerves a little bit less sensitive, which is a terrible outcome. So it's low, but it's not zero. I mean, I had somebody recently in my office that said, you said this wasn't going to happen. And I said, I'm sure I didn't say it wasn't going to happen. It's rare, but for men that already have impaired blood flow but weren't quite ready for an implant, then I still think it's a great surgery to buy them some time. And then when you do the implant, you hope, if they've done some kind of vacuum device therapy traction, that they've gained back or at least preserved enough length that you're able to put a better implant in them. So yeah, I mean, I think it's really serious. I mean, the best candidate for a plaque excision and graft is somebody that has physiologic or even super physiologic velocity. So I really want their pre-op dorsal artery their cavernosal artery velocities, to be in the 30s, 40s, 50s, 60s. Those guys have great erections. They can then, sustain a little bit of diminished vascularity. But yeah, that is the big dreaded fear of that surgery.
Yeah.
You can put it through it, and I tell these men, look, I can make your penis perfectly straight, but we also want it to function. So this is not a cosmetic procedure. It's a functional one. Traction's been around since at least 3,000 years.
Yeah,
it's not new.
You published this study recently on penile and foreskin stretching through the years,
JT
right?
Segalos, yes. Shout out to JT Segalos, our chief resident and good friend. That was a AUA history talk, and very entertaining, very enlightening, and I loved it. It was a great look.
It looks like there's even cave drawings from like 8,000 years ago, right? Showing men doing penile stretching.
Yes.
Yeah. So it's as long as we've been around, probably.
That's right.
I want to talk a little bit about fertility.
Yeah.
But before we move on to fertility, anything else you think people need to know about Peyronie's disease?
Yeah, it's not your fault. I mean, it just isn't, and I think that's my big take-home message is that we have treatments, we can fix it. We just need to know what the right pathway is, set the expectation, ask the patient what their values are, what they want.
Yeah. Let's talk briefly about fertility. I know we could probably spend another hour talking about it, but we'll talk about the high points. So I think one is that a lot of sauna use is up right now. And we know heat is not great for testicles. So are you seeing more infertility in sauna users? Are you worried about this?
Yeah, heat kills, speed thrills. The more motile the sperm, the better off your chances of conception are. And anything that raises your scrotal temperature, even a degree Fahrenheit, can have a pretty dramatic effect for a long time. Now, the thing about sauna is that you're not in there for that long, so your exposure should be less than 15 minutes or so. And your testicles are probably somewhat splayed out, so you're not in bike shorts when you're in there. So, and the Finns are a pretty fertile lot, and the Finns have been doing sauna for 2,000 years plus. I mean, ever since they kind of moved up to Lapland area. And so so there is some cultural significance. The benefits of sauna, the heat shock protein release, and all of this, the longevity data coming out on sauna, it's a very compelling anti-aging, anti-inflammation, anti-stress way to relax, to be in that hot environment, and then followed up with a cold plunge, right? To do the real true finish experience of going from 106 degrees or 120 degrees to 35. But yeah, in terms of sperm production, I do see it more in any other work or sports where the testicles are constantly compressed for a long period of time. in hot yoga, for example, when people are in hot yoga rooms for a long period of time, that I've seen diminished sperm counts from that. Saunas, not as much, hasn't been as well studied. And again, I think that it probably is that there's a little bit of cooling that goes on. But yeah, that is the hottest thing these days. And so I think it's everything in moderation, especially with heat exposure, is what I typically tell my patients to do. But they're doing something for them that's healthy. And I usually say healthy you, healthy sperm. And so I think anything in moderation, we need to do the studies to really look at that. But also we need to look at our cultures that have doing saunas for years and seem to be doing okay.
Yeah, that's a good point. And what about red light to the testicles?
So yes, the data for red light therapy was a paper from about 1938 of 8 men. It's amazing, when influencers get a hold of PubMed, and you just go back, and even to the Cochrane database, you go back pre-1964 and you see what comes up. Wow, there's this one study where totally uncontrolled, where, you just did some testicular tanning and saw T levels go up. Not a fan, don't see the data behind it. There's so many better ways to improve your testosterone, even holistically, not even through medication. That I don't recommend testicular tanning. But again, any observation, then let's actually do a clinical trial instead of just an 8-patient from 1936 observational study.
Well, if you're looking at red light specifically, I don't think it penetrates deep enough to get to the testicles.
There's that too. Yeah, or need the lighting cell to do
tanning
anything.
is separate, but I think people are like doing this whole body red light, and some of the reason being they think it's going to boost testosterone. I don't think it's getting deep enough. The data, at least on red light, is for skin level.
Right, for red light, exactly. I'm sorry, is you're looking at just maybe some kind of upregulation of collagen synthesis for skin improvement. But yes, but you're right. They're doing the idea being that somehow you're going to improve both sperm production and testosterone production through tanning or through red light. Yeah.
Yeah, and you've done some work on looking at supplements, supplement promotion for infertility and misinformation in that space. What supplements are going to help people if they're trying to conceive versus which ones are not really that helpful?
Supplemental sleep is one of the best ones. I love supplemental sleep. So, I wrote a book a couple of years ago. It essentially was, the kind of field guide to men's health, but it was all basically it's eat, move, sleep. Whatever you look at, before you start talking about supplements, before you start fine tuning your lifestyle, look at the big stuff first. And so then you say, okay, well, are you missing anything nutritionally? Are you not eating vegetables at all? Because we know from a fertility standpoint that high levels of antioxidants really good for the seminal environment. And one of the things we look at in men, even with normal semen analyses, can have an elevation in what's called reactive oxygen species, which basically causes the DNA to be more fragile and lead to poor fertilization and even poor embryo development. And we can fix that. We can decrease the reactive oxygen species with really good, healthy diet, increasing polyunsaturated fatty acids. So tree nuts are great. Any dark leafy vegetables, any blueberries. What does that mean on a supplement level then? If you say, look, doc, I can't stand vegetables. Kale is anathema to me. I don't want to spend $20 for a smoothie at Erewhon. Then what can I do? And then, right, some of the ones that have been studied forever, CoQ10, L-carnitine, folic acid, vitamin C is a pretty heavy hitter because it's such a good antioxidant. And there's really good data to show just vitamin C alone, 500 milligrams, can reduce your reactive oxygen species. There are a lot of supplements that are out there that are all combination therapy. And they are just basically one or usually 2 capsules of all of those antioxidants rolled into one. And so what I do is I think one of the supplements that, without any financial interest, I should say, is a supplement of Austria called ProFertile. The reason I like it is they actually do data in European studies. The governments often sponsor nutraceutical studying. So if you want to look for most of the data on nutraceuticals, you look outside of the United States because we don't fund any data. So it's going to be industry sponsored. So whatever company that you're looking at, maybe look outside of the States and see. But ProFertile has pretty good data that their supplement, which is a mixture of essentially everything I just said, probably with some proprietary ingredients, can decrease DNA fragmentation index. So it means the DNA is healthier, can decrease reactive oxygen species. And they even have some live pregnancy data. Having said that, the AUA guidelines for infertility still don't recommend any supplement that there's enough good evidence, level 1 data, that you should be on it. So for me, I'm not in general a huge vitamin person unless you've done everything right? So if you're just totally dialed in, you're sleeping 8 hours a day, you're exercising 30 to 40 minutes a day, your nutrition is great, and you just want to, super perform, then we can talk about adding supplements. But I think, unfortunately, for most people, it's a shortcut, and they're missing the long route, which is to just take better care of themselves and improve their overall health. But so when I see a man in my clinic, I give him a handout of all of the randomized controlled data, which are basically the 4 or 5 I just mentioned. Selenium is also on there, 80 micrograms of selenium, and say, or you can just buy it all in one. And here's a couple companies that have an all in one. And if you go and buy it at a decent, reputable supplement shop, then you probably save yourself about $30 a month. So it's not a huge savings, but it's reasonable. You just got to choke on about 8 pills instead of 2.
In terms of fertility, we're seeing, at least in semen counts, they've done some pretty major studies that have looked at a decline in semen counts and concentration over the last 50 years. Why do you think that is?
Yeah, I mean, this is kind of a bit of a chicken little thing for me. I mean, for one thing, I'm kind of excited we're talking about it, because as a male fertility specialist and a reproductive urologist, we've sort of been backseated since the 80s when IVF came along and we can take 2 sperm and make a baby, which is still true. In fact, it's amazing what we can do for men that have really, really reduced sperm counts, even some that have 0 sperm in their ejaculate. I can go in with a microscope, find sperm in their testicle, and still create a biological child for that man and his partner. So I love that because we're talking about it, but then I also don't want to scare people in thinking, is this truly something that is happening? Is our Y chromosome really shortening, and is our fertility really declining because of what? And I think it goes back to, is it the carpet we're sitting on? Are there phthalates in the carpet? Is it the bisphenol is in our plastic, in our water bottles? And there's so many different environmental mutagens. But getting back to the big picture, we also are not farming and plowing anymore, and we're not doing walking up 7 flights of stairs because we all have elevators. And so there's a lot of change just in our overall health. One of the things I'm super interested about, though, is that our microbiome was also changing pretty dramatically. And we have some pretty cool data coming out. We've had a couple of papers. Vadim Asachi, who's our research resident now, has been leading this because he had a background in gut microbiome, and we brought him into urology. And we actually have studies showing the seminal parameters of men that have subfertility. The microbiome is a completely different biomap than those that are coming to me that are perfectly fertile. So we set up the study pretty simply and saying, hey, Dr. Mills, I had my 2 kids, I'm done. Would you do my vasectomy? I said, yes, but first, how about this? Would you give me a sperm sample? And I'll do an extra good vasectomy. And we did.
Everyone gets an extra good vasectomy.
Exactly right. Everyone does. Yeah. But no, I was very grateful to these men that volunteered, IRB approved, of course, for us to look at their microbiome in the fertile couples, and totally different. And it's really, really cool. So maybe it kind of goes into everything else that's wrong with us today, is that maybe we have a massive antibiotic exposure. You just, if you're 3 and you get a sniffle, you get ear tubes and you get antibiotics. And so we've really changed the way that we interact with our microbiome. So I'm super excited with that. We want to expand that study to looking now at the partners and seeing, what their cervical microbiome is, and see if there's a mismatch, because there are higher rates of abnormal vaginal microbiomes in the men of infertile couples too. And so it probably goes both ways. Some of the bacteria that we typically see in a vaginal flora that maybe are pathologic are ending up in the male seminal microbiome. So that is sort of a plug for maybe that's one thing we haven't looked at. Everything else, it certainly goes back to just all of the environmental mutagens that are around. But I'm not an alarmist that way. I think, again, it goes back to, before we talk about why your sperm counts are low and who can we blame, let's talk about exercise. Let's talk about weight loss. Let's talk about what we can do to get you in better shape. Let's talk about the stress. You're coming to me on your lunch break or between jobs because you just been overnight working, down at the Longshore, and here you're on my clinic, and then you're going to go off and drive Uber for a little bit, and then you're going to try to have a baby. And so I think the idea of stress and strain, especially in expensive urban environments like I practice in, is real. And I think that's where we're seeing the fertility decline. We're having babies later in life too, and one of the things we know is that as we age, our semen in general does get worse, and that is in fact part of our new AUA guidelines for infertility, which I don't think are embargoed yet, and they may have been the older one, but as I'm reviewing them, that we really have to recommend to people, if you're over 40, you may have impaired sperm production already. So if you're trying to conceive at 40 or greater, you may already be in some trouble. So that's real. And then we also know that as women age, even if they have good ovarian reserve, the eggs have intrinsic DNA repair mechanisms that aren't as good. So if you have 23-year-old eggs versus 37-year-old eggs, they may be fine if you're dealing with 22-year-old sperm. But if you're 37 and your partner's 46 or 50, then that sets up risk factors where your eggs are not able to repair the abnormal DNA in the sperm, and the sperm itself is already not as good as it used to be when it was 20. So there's just so much to go in to unpack, and there's a lot of great literature coming out. There's a new sperm banking, relatively new fellow started by Jim Smith. Again, I have no interest in him, but I'm interested in their science because they have a repository of tens of thousands and soon 100,000 semen analysis for all over the country where we can actually study this stuff. And they're making a big investment in trying to figure out how we can actually get answers to the question you just asked. Is there a zip code dependence? Is there a difference between the semen analysis in Orange County versus Long Beach versus Santa Monica versus the Valley? Yeah, there is. Why? Don't know yet. And these are the things we got to figure out.
Yeah, and I think stressing about these things, like why is this happening? What's in the environment? What's like, who's to blame, is actually just harming us, right? Like there's so much, especially on social media, there's so much, guess what you didn't know, like this water you're drinking is like got whatever minutia of something in it and you're going to be in trouble now.
Right.
And so I think that stress is really under recognized. Like that is causing probably way more problems than whatever they're telling you is causing you problems.
Right. Well, and you bring up something tangentially, which I see all the time, which is the social media circles of like, here's our baby reveal and here's this. And then the FOMO of the couples that are in my office saying, everybody in our group now, they all have toddlers and like, we're just sitting there trying to figure this out. And it's pretty devastating.
It really is.
And just the whole idea, especially from a male factor, we had a very nice discussion about the psychological trauma of Peyronie's and dealing with that. But the male that has a difficulty initiating pregnancy he's a fragile male. I mean, it is a devastating thing to say, this is what defines me. I'm a sperm producer. I mean, that's what I am as a man there's a person born with a penis and testicles. To not be able to conceive is something that we need to spend more time on acknowledging and trying to help men deal with that. And we definitely need more counseling. A lot of the counseling and fertility, and this is my plug for Men's Health, is really mostly looking at the female side of things and the devastation of infertility. But man, these guys are wrecked. We really have to take care of them. Really have to, try to first of all, do everything we can, to find a good solution for them. But also, not everybody's able to, every one of my microtestes is not successful, unfortunately. So every time I go to the OR trying to find sperm, it can be a devastating conversation. It's so one of the things it is the hardest thing I do. I mean, it is the hardest thing I do in medicine.
That is one thing I will say. I have a lot of female friends who've gone through fertility issues, and there's like, there's they support each other. There's this great fertility warriors. There's like, hashtag fertility warrior. There's like all these things, right? And they really support each other. They become like sisters. They become this really bonding support for each other. And I don't see that for men for most things, right? But definitely not for infertility.
It doesn't happen at all. And I don't know the social media world that well, but I know enough of couples that have struggled for fertility that where there's a male factor where that isn't mentioned. It's not mentioned, and it's all, we struggled for fertility, and everybody assumed it was on her side, but it's not. It's not, and there's no place for that guy to go. I've yet to meet somebody that wants to be a public figure and say, I want to share my struggle. I've had men for erectile dysfunction, for Peyronie's disease, my entire career is dealing with the most sensitive issues that men face. And I've not had a spokesperson that wants to come forward and talk about their fertility journey. And of course, I'll never ask. I should mention that I feel bad now for Anthony. I had a great patient who's a spinal cord injured man that I helped, and he actually has a foundation. And so he, I think, A, is an amazing person, but B, because he has more of an obvious reason for why he has fertility issues that has nothing to do with his sperm production, but we just need a little help to actually create the embryo. He's very public about that. But for everybody else that doesn't have an obvious cause, it's very difficult for them to share that.
Yeah. Well, if anyone listening wants to share, reach out and we'll help you. Or I'll help you.
I love that.
But I think it's important. It's really important. I think that so many men struggle, and when they have a supportive partner, it's helpful, but that's like the only person they have. They don't really confide in other men in that way as friends, or other women in that way as friends. At least in my experience, it's very few and far between. So it's really challenging. It is very isolating.
Yeah, and it's isolating. The conversation you have with men when the partner leaves the room, that they can't share with her what he's going through, is also equally difficult, because he's feeling that guilt, that shame of not being able to initiate a pregnancy, and how do you talk about that? And the partners, at least in my office and in general that I've worked with, have been amazingly supportive, and we've done a lot of great work with donor sperm where we can initiate pregnancies. Just a different conversation. And so yeah, it's never over. And there's always a solution. There's always a way for couples to be together and to raise a child together. It doesn't have to be, straight biology. And I think that's the other message. It's a hard conversation to have, but it's one that at least you always have some degree of hope that's available to these couples. But yeah, it's a rough conversation.
It really is a serious ending. Let's end on something light.
Yeah, please.
Is caffeine going to hurt your sperm?
Oh, I'm pretty much a practice what you preach kind of physician. So I love coffee. Oh,
Me
man,
too.
I love coffee. I have very strict coffee protocols, though. Everybody that works with me in clinic, it is, get up in the morning, hang out with the dogs, probably about 5:30 to 6:30, have 2 cups of coffee, go to work. Very busy clinic, very busy OR, and then every day at 3:00 I have to have 3:00 coffee, and it's perfectly timed. So if you think about the caffeine, we learned in medical school it has about a 6-hour half-life. 3:00 I have coffee because got to make it through the last 2 hours of clinic or the last case of the day, and then I like to hit at the gym about 5:30. So I'm peaking. My caffeine is peaking 5:36. And then by 9, when it's bedtime, it's gone. It's out of my system.
That's good.
So that's my view on coffee. Is I think the data around coffee, good, strong black coffee is great for type 2 diabetes prevention, potentially for preventing onset of Alzheimer's disease. A lot of this is Scandinavian data, and for improving sperm parameters to a certain point. So just like everything else in moderation, right? So we know that about fewer than 4 cups of coffee a day seem to be good for just about everything, from diabetes prevention, Alzheimer's, mental acuity, and for sperm production. Anything more than that, then you have to ask, why are you having 7 to 12 cups of coffee a day? Is it the caffeine that's killing you?
And the size of the cups.
Yeah, that's right. That's true. And is it the coffee that's killing you, or is it the fact that you're drinking so much coffee because, again, you're working 3 jobs
and you're not sleeping?
Yes, exactly. Yeah. So
for me... Well, be careful. Some people, me in particular, I will just give my example. If I have a coffee afternoon, I have a hard time falling asleep, even if I work out that day. And so I have to be cautious and be thoughtful about when I have my caffeine. Right. So everyone's a little different. The half-life is 6 hours. So at 12 hours, you'll still have some on board. Yes. And some people are more sensitive. So it could be making you not sleep at night.
Yes, could be. I never did the 23andMe to know if I had that caffeine gene, but I think it is my superpower.
That's a good one.
I
wouldn't hate that.
Yeah, I wouldn't hate that. It keeps me up, it keeps me lean, it keeps me energized. And
it doesn't affect your bladder, apparently. So
that's right. Yeah. No, that's right. Well put. So far, so good.
Good. Great. All right. So we do end the podcast podcast with some just questions. They can be related to your specialty. They can be related to just anything, really. So first is, what is something you know now in life that you wish you learned earlier?
There's this thought you always play hungry, you always play angry. That's kind of how I have done everything. We're very type A people when we become surgeons. But I do think the older I get, the more I realize that I don't have to all do it today. And I'm still working on it. I've still got at least 15 different major projects I'm doing at UCLA and in my practice, as well as, in my landscaping I do around my house that there's time. Yeah.
It's fine to do it all, but just set time for each of them. And as long as it's not affecting your whole life, it's okay. What's a non-negotiable, something you have to do every day? Except I already know about your 3 p.m. coffee, so something else.
I have to read something non-medical every day. Ever since medical school I would read, I usually have 3 books going at one time, at least 2 nonfiction and 1 novel. And so at night, I at least get a good 15 to 30 minutes of reading in that is non-medical. I was a literature major in college, and I think it probably goes back to that. I truly love the philosophy and deep literature that makes you think and makes you try to figure out how to be a better human being every day. So reading and non-negotiable. What's
a good book you read recently?
Gosh, there's so many fantastic books. I'll tell you the one that I'm reading. The 2 that I'm reading now is one is the history of the Assyrians, the rise of the Assyrian civilization. I can't remember the name. It's by a Yale professor. It's the stuff that we barely learned in world history about, before there was anything else, the Middle Eastern rise in the culture, their ability to negotiate the world in not much a different way than we are now is fascinating. So again, I'm sort of a believer that our genome is our genome, and our response to it is what is cultural. And so I think humans are always going to do human stuff, just humans being humans. And so whether it's in ancient Assyria and warring against people that you're trying to get property from or trying to change dogma with, we don't change much. And so it's good for me to get that historical perspective. And then my favorite novel that I've read recently is The Heaven and Earth Grocery Store by James McBride.
Okay.
It is amazing. I read all of his books to this date, and it's blowing up now. But it's a brilliant story set actually in this little town of Pottstown, Pennsylvania, which I know because one of my sons actually went to school there. And it is it's a great story of the interaction of Black culture in the pre-war era and Jewish culture and immigrants trying to negotiate an incredibly racist world of rural Pennsylvania in the 1920s up through the 50s, and just the love and the compassion that people have, and the bounty of goodness that we can do for the right thing. And if it's one person doing it, the lives that they can change, it's just breathtaking.
I'll have to add it to my list. I do love to read. I don't read every day, although I really do. I love, and I go through phases. I'll be reading like all nonfiction for a while, and then I'll read like all fiction for a while. I think recently I've been in a fiction kick, and I read The Fourth Wing and that whole the 2 books, and that was really good. Just like a really well done like escape from the world. Great book.
Right. Yeah. But all of those again, it's human nature just put into a culture that doesn't exist.
Yeah.
But humans being humans.
Same thing. Yeah.
Right.
What is a health hack or life hack you'd share?
Other than coffee, my health hack, I think, is you always have 20 minutes to do something greatly physical. And so really good literature. And I tell every patient this, that, for about $40, you can buy a heart rate monitor. If you can't buy a heart rate monitor, I'll teach you what to do next. If you can get your heart rate up to 80% of your maximum for your age, which for a guy like me in his mid-50s should be 130 to 150, but I'm a gunner, so I try to go a little higher. You do that for 18 minutes a day. What that does is it burns out all of the glycogen in your liver, which is your immediate sugar release stores, and that's when you really actually start to get great physiology. It improves your cardiac status. It's 20 minutes. If you don't know what your heart rate is or max, just whatever you're doing, if you can't finish 2 to 3 words because you're so out of breath, so whether it's a Peloton or whether it's just running outside or swimming, that is getting you at about 80% max heart rate, and that will cure almost anything. It's amazing. But the people that exercise but really the guys that are going to the gym and spending more time reading or doing something else and hogging up the equipment, they're not really doing themselves any good. I mean, I have a busy schedule. I do a lot. So I got to get at least those 18 minutes a day of just vigorous, like I'm breathing hard exercise.
Yeah. Yeah, there's definitely value. It's a mortality indicator, right? Your VO2 max, or the ability to oxygenate based on your cardiovascular health. And so it's so valuable.
It makes you feel really good, It's an endorphin rush. It's good for your libido. It's good for your nutrition because you want to eat healthier. If you just burned all those calories, you don't want to have a Snickers bar. You want to, I need some, fresh watermelon or something.
Yeah, absolutely.
Which is another good life hack.
Watermelon,
citrulline, highest concentration of citrulline in the known universe. So It's a great recovery fruit.
Yes, it's very good. It's very good. There's actually been like a couple studies looking at for erectile function. And I mean, he had to drink like 6 glasses of watermelon juice or something, but it worked.
I'm on it. I'm on it and I will do it. It's citrulline, baby. It's all citrulline.
Yeah. And then what's one thing you wish would change about the world?
I only get one.
I know. There's so many. I always have to preface it by there's so many, but pick one.
I think it's the perception of always being threatened. I think if we can figure out how to not always feel threatened, either by opposing countries or opposing people, then life would be better and we'd be able to trust people a lot more.
Yeah, I agree. All right. Well, thank you so much. It's been an honor to have you. Where can people find you?
Yeah, it's a great question. I actually don't really do social media. You can find me at UCLA. I've just never gotten into the deal so much, but we have a very good website at the men's clinic at UCLA, and we do have people that are doing social media through us. But yeah, that's one thing I haven't figured out how to put in my day. So yeah, I'm all over. If you Google me, I got a lot of YouTube videos and all the other stuff out there that, and then come see me if you need me.
Awesome. Thank you so much.
It was absolutely my pleasure.
Thank you guys for joining us on today's episode with Dr. Jessie Mills. I hope you enjoyed this so much. If you did, please be sure to leave a rating or review on your podcast platform of choice, as this helps other people find our podcast. And be sure to subscribe to our YouTube channel. This is an easy, zero-cost way you can help support us so we can continue to make free educational content every week. And as always, remember to take care of yourself because you're worth it.